Welcome to Eye Contact. I am Dan Epstein. I'm talking to Dr. Marc Labetoulle about the latest development in ocular surface imaging. Welcome, Dr. Labetoulle.
Welcome.
Remind us of the evolution of ocular surface imaging in the last 20 years, please.
Well, I think that the 20 last years were very important for the entire field of the ophthalmology and specifically in imaging, not only in the retina, but as well for the ocular surface. 20 years ago was the introduction of the optical coherence tomography for the retina, and very soon after it has been applied to the ocular surface and the cornea. At the same time, there was the development of the in vivo confocal microscopy, which gave us a lot of details about the homeostasis of the cornea. Now, it is clear that imaging the cornea is a whole part of the anterior segment examination.
OCT, ocular coherence tomography, continues to evolve. Tell us about the latest systems as they apply to the imaging of the ocular surface.
Well, I am not able to go, to be honest, in technical details for the optimization of the OCT, but what I know about this is on a clinical point of view. It is clear that the OCT is becoming more and more precise with time, with the field of the image that is wider now, and then we can use the OCT for examining the cornea as a whole structure, including the anterior segment and the relationships with the iris. The details are more and more small, and we are able now to see the different layers of the cornea, so we can go very further in the observation of the different diseases, including genetic disease of the cornea, including abnormalities of the endothelial cells, etc. So this is, again, as I said before, very important imaging tools.
How do we integrate in vivo confocal microscopy and OCT?
In vivo confocal microscopy provides a lot of details again about the interior of the cornea. It has become clear that with time that, for example, dry eye disease is a disease that is related to an involvement of the corneal nervous system and the corneal nervous network. IVCM has shown that there are modifications of these corneal nerves together with infiltration of inflammatory cells and other modification of the stroma. So IVCM is not only something that is able to image the cornea at the time of the diagnosis, but also is able to help us for following the patients and to optimize the treatment according to the results of the IVCM. And at the same time, this is complementary to the OCT, which is able to give us an information about the depth of the lesions, the precise location in the stroma.
When Confocal came on the market and became available clinically, there was great enthusiasm about its use. It never really made it. OCT has been more successful. Is that not your impression, and why?
I think the main reason is that observing the cornea with an OCT is much more easy than with the IVCM. It is not very difficult to acquire the image with the with the OCT, while this is very difficult to make a good analysis with in vivo confocal microscopy. In vivo confocal microscopy, in my opinion, is like echography many time ago. If you look at the still picture, you can't see a lot of things, but if you follow your examination, if you do it yourself, you will have much more details than if someone does it for you.
I fully agree. That's an important distinction. Has the evolution in imaging changed the way we evaluate the common problems such as dry eye disease?
Yeah, clearly the imaging of the cornea has changed the way of thinking the dry eye disease. It is not, it is clearly not a question of aqueous production or even evaporative disease. This is now a disease that involves the corneal network, the level of inflammation in the ocular surface. In the 90s, when this idea was emerging, the inflammation of the ocular surface disease was just an idea. There was a few clues about this, but now we can image these inflammatory cells in the cornea. We can follow them, we can quantify, and we can again check that the treatment is decreasing the inflammation and at the same time is restoring the corneal network.
Can you share your experience with ocular imaging in cases of severe infection?
In severe infection, corneal imaging is also a very important tool because we can check out for the presence of fungi, especially filamentous fungi. We can look at the presence of acanthamoeba. So when we are facing a very severe keratitis, it is important to proceed to these imaging techniques if we are not sure about the diagnosis. And I would like just to remember a very important publication 10 years ago showing that even the most experts in infectious keratitis were not able to classify the keratitis according to the gender of the species of infection. I mean between fungi, virus, bacteria, and acanthamoeba. So we cannot believe, even if we are experts, that we are able to make the proper diagnosis just with our slit lamp, and we need everything we can, and for in that purpose, HRT and OCT are very important.
That was very important for the audience to understand, that you cannot just use a slit lamp anymore.
Yeah.
Thank you very much, Dr. Labetoulle.
Thank you, Dr. Epstein.
For more information, visit us at eurotimes.org.